Welcome back to Access Point. I'm your host, Chip Hughes, and I'm joined today with
Joel Burleson. Burleson Davis, thank you for joining us today.
Did you forget that? You forget there for a second, Joel? What happened?
I mean, yeah, I'm still struggling. Like I had a birthday party this weekend. Took a long time to cut. Like there's a lot going on. So
That's great.
I'm surprised I know where I am right now.
Yeah, well, I mentioned it in the podcast, but happy birthday again.
Yeah.
So I hope it was a great one. So fun conversation today, obviously. We had Dr. Sean Kelly, who you and I work with on a daily basis on the call, but what stood out to you from our conversation?
Yeah, I think the most interesting thing that stands out, especially when talking to Sean and interacting with all the people he introduces us to, because he's super famous in the healthcare IT community, is the fact that doctors, nurses, clinicians are forward thinking. They want new technology. They want technology to solve problems. They aren't the wall saying don't solve that problem for me, but they are loud when your problem solving makes their life worse. So I think it's just really useful to like you know take that frame of no's from that community tend to be no because you're making things worse rather than better. Not no, I'm a Luddite and I don't want to deal with technology.
Yep. I mean, we focused a lot on sort of passwordless and where that sits, which
Mhm.
is obviously Sean works at Imprivata too. He's our chief. We let him introduce himself, but chief medical officer. I always like hearing the passion, especially
Mhm.
when he gets going on particular topics. And it's always interesting to me when you start hearing him talk about this combination of security and passwordless, and then he starts talking about what he actually does on it when he's going through one of his clinical shifts and sort of bringing that together. And it always sort of grounds me in how important it is to go get this right. And then just how far we still have to go, which is really, really sad in some respects.
Yeah.
Um,
Yeah, folks in his shoes have like a visceral understanding of what needs to happen.
that's right. And just, bringing in security, that security matters. It's
Mhm.
got to be fast, but it also has to be secure. And then you brought up patience as a part of the conversation too. And I thought that was interesting. That was new for me, sort of how valuable it actually is to be able to identify a patient. And that's sort of different in terms of where that hits. So I thought that was a nice part of the conversation.
Yeah, I think a huge issue that we still need to deal with as an entire sort of industry and country and world.
Yep. And I think, last thing we closed on was agentic, obviously a little bit, and so buzzy right now. Sometimes I get hesitant to talk about it, but I think, we probably should do a podcast on it, just what it means, because heaven knows I'm reading a lot, and I know you do too, just to stay up on top of it. And we have thoughts on what we can do. But, um, you know, Sean's thinking about it, and I can tell you that he's talking to a lot of other doctors who are thinking about
Mhm.
it. So, at least for me, that's the piece that definitely sort of stands out and where hospitals are going with it.
Yeah, couldn't agree more.
Yeah. So, well, cool. Well, I think it's an interesting conversation. So we are thankful for Sean for joining us. We're thankful for having him here at Imprivata, and we hope you enjoyed it. Enjoy it. Please download, like, and subscribe, and let us know. I'm excited about our guest today. So we've got Dr. Sean Kelly. So I never know, Dr. Kelly, Dr. Sean, or just Sean, whatever one you want me to call you on this podcast. Why don't you introduce yourself quickly?
Hey, any of the above works, Chip. We have an inside joke in the ER that anybody who comes into the ER demanding to be called doctor as a patient probably isn't a real doctor. Like, most cool doctors don't take it too seriously. So you can call me whatever you want. I've probably been called worse, but Sean works, Dr. Sean or Dr. Kelly, whatever you're comfortable with.
Yep. And obviously, for those who don't know, Sean works at Imprivata, and so we talk daily, I think almost hourly, sort of across us, because he's a big influencer of our business. So you have one of the most interesting roles. Our CEO Fran has talked about you in particular as being something really different that you do here at Imprivata. So why don't you just give us a quick overview, Sean, of what you do at Imprivata and your role, and maybe just a little bit of background how you got here.
Sure. So I'm the chief medical officer. I head up healthcare strategy for our customers and our product. And basically, I try to break or give feedback on everything that Joel and Chip try to make. And I try to act like an internal subject matter expert as a voice of our customer. and then also a bridge to our actual customers. So we have grown a big team of practicing nurses and pharmacists and techs who grew up in healthcare, and a lot of us not only in the front lines but in leadership positions. So we've kind of felt the pain of the workflows out there in the real world, and we take that voice back into the company on that iterative product development cycle. And the long and the short of it is it's really, really fun and really gratifying. I mean, half the time I'm just belly aching about workflows and problems, and the product people really like it, think it's really smart because it gives them good insight. But for me, it's just cathartic because I get my voice heard and our customers' voice heard. And we try to improve the products. And so we feel that's a natural fit, and it's been a really enjoyable experience.
Yep. And you did say, right, you're a practicing emergency room doctor still. You do that, what, about once a month? I always curious how often you're in there doing
Yeah,
that.
I do. I do a few shifts a month, and it keeps my hand in it. Emergency medicine's it's a really fun practice because you have to know enough about everything to treat the acute part of it all. So, as part of that, you kind of know a lot about like all workers, different workflows and needs, everything from pediatrics to geriatrics, and community to city hospitals and academics, and sort of everything in between. Proceduralists as well as the thinking game of internal medicine, and so, it's a pretty gratifying career. And then functionally, it's shift work. So I work really hard when I'm there, but when I'm not, I can take time off and do things like this. So yeah, I still practice. I still drink our champagne, as it were, and I experience that intersection of what technology means to good access and what bad technology when it prevents bad access. I feel that pain too.
Yep.
Yeah,
That's great.
and that makes me sort of think about maybe a topic to start us off here. So there's been a lot of discussion about like cybersecurity is patient safety, and it's really like technology is patient safety. But there's not for many of us that don't practice we're like, what does that really mean? Like how can you translate that? Like what are we really talking about when like security or identity means patient safety?
I guess think of it this way, like, good access management technology, whether that's for cybersecurity or for productivity, or hopefully for both, that's the gateway to every single thing that we do in care. It's no different than other tools we use in medicine, like a stethoscope, but arguably much more powerful. A lot of the data that we have on hand, that's what we use to make diagnoses, to order things, to activate teams, to communicate, to collaborate, to diagnose and to treat patients. And without access to that, it's really hard to care properly for patients. I'll give you a couple examples. I had this real experience where I was working, and a code stroke came in. That machine, I hadn't been on that machine yet, and I tried to open it up. The little words that come up when it says, for Microsoft starting, and it says, the system is booting up. This may take a couple minutes.
Oh yeah, like please wait, user
Yeah,
preferencing being
big
set or
blue
whatever.
screen with white words. This may
Yep.
take a couple minutes. Well, you don't have a couple minutes when someone's having a stroke or they come in a trauma. Those are very time dependent. So you really need to let doctors and nurses and other workers get into their system as fast as possible, because you need to know, is that person on blood thinners? Are they taking these medicines? Are they allergic to that medicine? And we have something called a code stroke where we hit a button and it alerts everyone. It tells people in the CAT scanner to clear that out because there's an emergency case coming in. It gets a transport person to come over. It consults the entire neuro team. It draws up whatever records we have so we can review the past CT scan and the med list. It activates a whole team in the ER, the person up front, overhead pages saying code stroke room, whatever. And none of that can happen until like I get access or someone gets access. So speed is a really, really important aspect of what's needed for access. On the other hand, security is really important because if there's a breach and ransomware, the whole hospital goes down. And there's been some great data that's come out from UCSD and elsewhere where a gentleman named Christian Demeth, who's a friend of ours, wrote a paper just talking about both the financial and then also the clinical implications of when a hospital's on diversion. A hospital in San Diego went on diversion for weeks, and people couldn't go to that hospital. They went to other hospitals where, guess what? They didn't have records, or it was harder to find their records. And they had repeat testing, they had unnecessary testing, they had real morbidity and mortality, so harm and death that happens. And so there's a financial cost, there's a brand and a trust cost, there's ransomware that you hear about. And if that information gets out, obviously you know about this too, that's a treasure trove of data for hackers. And so they know they can get high levels of reimbursement for the ransomware to get to people, hospitals to get their data back. But if they sell that, it's worth lots and lots more than financial data because there's often financial and demographic data plus other data that you just can't get back. You can't put that toothpaste back in the tube. Once it's out that a CEO of a company has cancer, that information's out. You can't make someone whole just by giving them money back. So I guess in summary, Joel, like it's everything. Like data and access and identity is everything in healthcare. Nothing happens for a doctor or nurse until they can access those systems. And seeing the human being that's actually the patient is only part of what we do because it's so complex that we need access to that data for patient safety and care, but also to keep it secure.
Yeah, and to sort of paint a little more on that, like I know there's some sort of, I don't know, traditional like knowledge that's like, hey, if access sucks on the floor, they'll find a way to circumvent it and go around it and do other stuff. But like more and more these days, it seems like that's less and less of an option, right? Like everything is digital, everything is, on some sort of system, like access is needed. And so like the opportunities to circumvent that are becoming less and less or harder and harder to do. And so which makes, access, especially like, IAM based sort of digital access even more important.
Well, this gets right at the crux of it because yes, it's lots of systems are locked down, but people are really good at workarounds, right? And doctors and nurses, if they feel like they're doing a workaround for the right reasons in order to get to care, there's amazing things that they manage to do. And ironically, the more you try to lock a system down and create a 16 character password with special characters, the more likely they are to just write that down or share it or come up with another workaround. And so I'll give you a couple examples. We had one hospital where their baseline number of help desk call-ins for password reset went from like the 500s. This is a big, big system. It bumped up to in the thousands on one single day, went up to like 10,000, ridiculously high numbers of call-ins. Turns out what happened is they painted the wards. So people were writing passwords, shared passwords on the walls next to all these computers where they would get into them. And they had painted over them. So all these shared passwords that they had used, nobody could get into. It's a ridiculous story, right? But it just shows human nature. And like one of my favorite pictures is someone did a presentation at a poster of a student campus and it had all of the sidewalks where they had built the sidewalks. And then you saw everybody and all the footpaths going diagonally across where people needed to get from point A to point B in bad weather. They didn't want to go all the way around the corner. They just went cut straight across. So human beings are really good at workarounds. We had another unit coordinator who their legitimate job was to look at the screen and not touch a keyboard or do anything on the screen because they were like air traffic control trying to say where patients needed to go and what they needed to do. So she stole the blood agitator machine that basically just moves around constantly and she put her mouse on it so that she was always moving her mouse. They sell those now. In those days, they didn't even sell them. The lab guy was infuriated because he came by and realized it's his $2,000 agitator machine was stolen to move a mouse. But that's the kind of stuff we do to get around security when it's onerous with passwords.
That's a lot for what it's worth, just off the top. So I guess, Sean, how do you think we fix that? What's your perspective on that front?
We modernize, like there's always this sense that doctors and nurses don't like technology, and that's bogus. We love technology. We all have iPhones, and we a lot of us are early tech adopters. We just don't like bad technology. So good access technology that's modern gets really exciting, right? Like you give me options and make it fast and make the right thing to do actually easy. I'll do it every time. I mean, look, doctors and nurses want to do the right thing. Like we swear an oath to do no harm. We just, when forced, we're going to do something that's fast. But if fast is also safe, we're all for it. And even if it's, um, something that is, out there in the world that we're even just starting to get used to, something like facial biometrics, I think we can actually be early adopters if it helps our workflow and if it makes sense to us. And so To answer your question, we modernize. We come up with passwordless, and to my mind, that's not one authentication modality. Like, I think facial biometrics is really cool. I don't think that any vendor should just be all about just facial biometrics if they're a real access management platform. I think there can be up to 8 or 9 different methods to get in, and really there should be workflow orchestration to mix and match those for the right scenario at the right time, right? Because facial biometrics are really great, but there might not be cameras everywhere. So you want to mix and match these things.
Yeah, I think there's a really important point that was sort of buried in what you responded. And like I've seen that out, talking to customers out in the field, is that, like sort of technology rollout and technology adoption is really successful when you like bring your sort of clinicians along, and they're usually, huge champions and partners and getting it done right. But if it sucks, they will kick you out of the door, right? Like it's not like that's not okay. But the interesting thing, right, when we look at the healthcare sector, is like the like basic paradigm of security around passwords hasn't been kicked out the door. Although I think there's been a lot of kicking and screaming. So, like, what's some of your perspective about why is that still happening? Why is that still sort of hurting healthcare? These old modalities.
I mean, there's definitely an adoption gap. I think there's a large percentage of people who want to move forward, but the devil's in the details, and you really have to consider those workflows, and you have to consider rolling out these methods in places that make sense for the right user at the right time. And that may be a progression, right? Like, we may not get rid of passwords entirely, but can you mask them and put them in the background so that I only use it once or twice a day or upon emergency, and or eventually not even use it at all, but it's still functioning in the background with some of our legacy technology, because we have a lot of legacy technology. We have a lot of disparate systems in healthcare, and it's not like that's going away right now. But with a modern IAM layer integrating into it, it gets a lot better. And at the end of the day, it doesn't matter if there's some complexity underneath that IT and IS can work with strategic vendors like Imprivata to solve, as long as to the end user doesn't feel that way. Like, ultimately, we want that to be invisible, and we want frictionless access. And so, look, Joel, if you give me the ability to use my face, and maybe the system knows there's a password in the background, but to me, I'm on my laptop. It looks at my face with liveness detection. It's really fast. And there's a trusted device like passkey on that. That's 2 factors. That's passwordless. I barely know it happened. And as a provider, I'll adopt that all day, and I'll tell my friends about it, and that'll start catching on like wildfire. Ultimately, it's back to the workflow. For the end user, they care about speed and time and focusing on patient care. And technology is just that means to an end. It's just another way to get into the system and get my data. So it's got to be fast.
So I think you hit on a lot of different things there, like pretty quickly, actually, just sort of going through. And I think it's interesting, just, obviously we work at Imprivata. This is an Imprivata podcast. We're in a lot of different hospital systems, and people sort of know us for badge tap. And so I think we can sort of acknowledge that. I think there's passwords out there and there's badge tap, and the market's pretty saturated on those two things. I think sort of the implication of what you're saying, going back to the beginning, is it's still probably not quite good enough, at least from your perspective, from a security perspective. And is that, let's just start there. Is that a fair statement, or am I sort of overstepping from where you said?
Definitely. So there are issues with the security of that, and I think what's missing is it's a Goldilocks problem. We've set something up where everybody knows that there needs to be sort of 2 factor authentication, but 2 factor authentication for certain workflows has turned into a password and usually kind of an awkward token. Again, not very usable, can be phished, right? Can be broken, so actually not super secure.
Yep.
And it's almost always either too much or too little security. What we really need is adaptive auth and the ability in the background to run risk-based analytics, and that will basically adjust so that, like, if I'm just doing my usual thing from my usual places and my usual behavioral pattern, if I'm within the four walls of the hospital, if I'm always on machines in my ER that I'm usually on, and it deemed as a low risk behavior, don't torture me with something extra. Whether that's just my badge tapping in and out, that feels like a safer type of a grace period if it's all on my usual machines and my usual pattern. But as soon as something aberrant or more risky happens, then ramp it up. Like we need a step up authentication with a second or third even factor that comes up with a higher level of assurance. And so I guess the theme there is yes, the security isn't perfect with just badge tap. The workflow is pretty good. Maybe could be better in some cases, but especially when you're talking about things like remote access, Chip, that gets really risky really fast, especially in this day and age. And so in those cases, you really want to kind of ramp up the analytics behind the scenes because then it becomes much more suitable and that workflow orchestration is there. And when you think about it, we've been doing this for years with electronic prescribing of controlled substances, right? There's machine policy and user policy. And the combination of those two things lets the system know that for that user that's properly credentialed and enrolled in these different factors, A, B, and C, only those will be available if they're available on that particular endpoint for that properly credentialed user. And if they're not enrolled or it's not available, it won't appear in that workflow. And again, in the background to IT and IS, that's pretty complicated and hard to do. But on the front end, it's pretty elegant because for me as a user, all I see is the most easy option pops up first, and then maybe a second option if appropriate, which it always is required in EPCS. But we sort of solved it with EPCS. And so now rolling it out to other use cases, you can apply the same tools, the same logic, the same modality, and more. And that's where things get exciting because now you have all sorts of choices where you can ramp up and down the security and the ease depending on the use case.
Yeah, and like speaking of sort of remote access and use cases and populations that may or may not help with sort of identity and access, like a whole part that we haven't really talked about yet is like the patients. Right? Like it's like
Patients, do they
okay,
matter in healthcare, Joel?
I've heard like there's rumors that that's true. Like I don't know. Like it depends on I guess what news source you probably read. But it's like okay, it's like we understand doctors. It's like yes, doctors and nurses will adopt technology if it's useful. Like patients feels like a whole nother game. Like what do we do about identity in patients and hospitals and healthcare?
Glad you understand doctors. That makes me feel good. It's still an enigma to me. But yeah,
Good luck
let's
with
talk
that.
about patients.
Yeah, we don't understand ourselves. We don't know what we want. Never mind someone else knowing what we want. Yeah, patients. Look, it's long been a problem, long-standing goal of the Joint Commission and lots of other safety and quality organizations throughout healthcare. The dirty truth is we misidentify patients at an alarming rate, and we're talking about 10%, maybe even 20 or 30 in some cases, which is just terrible when you think about it. Like if your bank got your money to your account, only 90% of the time, I don't think you'd keep them as a bank that long. There's a number of reasons why this can happen. Misidentification of patients is really difficult. I mean, there are language barriers. There's people with medical issues and problems that are hard of hearing, and misunderstood, and not their sound mind when they come in. And there's intentional fraud. There's just fat fingering and manual errors. And again, systems are old and complex. And so there's a lot of reasons why this can happen. But the good news is good technology can help solve it. We just talked about facial biometrics, and that can be applied to the patient population too. Incredibly accurate match rates that can match human beings to their record, and even make sure that those records match. And so, that is a really important goal and actually quite achievable, and something, of course, that we've started to roll out. And when you layer in even additional technologies like ID verification, where you can verify a person is really who they say they are by looking at a government issued ID, that's even another level of trust and validity to that ID. And just harkening back to the very opening question you had around patient safety, there's probably nothing we could do in healthcare more important than just simply identifying the patient properly. It all starts with that. Without that correct data, everything that we try to do to diagnose and treat can be wrong. And bad data in is the upstream gets way worse downstream. And there's lots of costs to that, with duplicate records and overlay records and separating those, and the manual cost of dealing with all that, not to mention unnecessary tests or misdiagnosis or lawsuits and patient safety episodes. And it's terrible. There's a huge percentage of denied claims that are from misidentification. So solving even a small bit of that is you reap amazing financial benefits. But for me as an ER doctor, we should stop killing a jumbo jet full of patients every day. Like, it's still the second or third leading killer of U.S. citizens in this country, behind heart disease and cancer, now that COVID settled down. So it's an incredible problem with good technology that can fix it.
Yeah, and it's that's the problem just inside of a healthcare system. You talked about the story earlier about a hospital being on a diversion. You show up and you don't have your records, right? It's like the data is bad if it's a hospital you go to, and then if you go to a hospital you don't normally go to, there's no data. It's empty. You start from fresh and new. Which I think is a sort of a problem that the industry is seeing too, around the sort of patient access.
Yeah, you bring up a great point. And the continuum of care, look, most hospital systems aren't just four walls in a hospital. It's a whole cluster of hospitals and smaller facilities and freestanding ERs. And a lot of us are starting hospital at home programs. We're actually discharging people and having them at home and caring for them there, with visiting nurses and other staff. And so identifying patients on the fly, treating them, and identifying staff too. That whole identity problem and the identity solutions extends far beyond the four walls of the hospital. So when we talked before about quotes remote access, what does that even mean now, right? Like, we're intentionally making everything this widely extending layer. And so, from a security standpoint, obviously there's such a more depth and breadth of risk, but also of potential for the care. So identity becomes that control plane by which we can sort of govern the access and control it.
So I heard big cost savings if we can properly identify patients. I heard huge patient safety pieces that we can go through and address, right? Not giving somebody a drug that they're allergic to, that sort of thing, if we can properly identify a patient. And third, really, this is just getting more prevalent, right? I think a little bit, you've got digital assistants at home now that are going to be identifying both the clinician and potentially the patient, maybe even friends, relative. And you've got to make sure that you've got good control around all that. I'd be interested, Sean, sort of talk about that expanding, just where you think sort of agents, agentic, some of that stuff that we're hearing a ton from a market perspective sits in, because I know we've talked, that's even going to be another layer that expands this even further. So sort of where are your thoughts on that?
Oh yeah, the future's now. We made it through a good chunk of the podcast before we got to AI, but I would love to spend a good part of the rest of it on AI, because
That was restraint. From us.
yeah, but I'm actually, look, it's terrifying and exciting, because AI, and particularly agentic AI, could do a lot of good in healthcare. And so the amount of administrative and menial tasks that most doctors and nurses have to do is staggering. We're not operating at the top of our license. We're burnt out, and staff retention is hard, because there are a lot of clerical and, quite frankly, even some of the medical things we do because of billing and compliance. It's high ticket items. It matters a lot, but could agents start doing a lot of that? Absolutely. And I think that that's going to happen at a breakneck pace. We're already starting to see some of it. And when that happens, securing and provisioning and managing those identities, those non-human identities, is going to be incredibly important. And so what exactly does that mean? And maybe we'll talk through a couple examples. There's a couple different forms that can happen, right? There's sort of human in the loop, agentic AI, where you've got agents that are acting on your behalf that are off doing things. And some of them may be perceived as more administrative, but honestly, in medicine, even administrative tasks that are seemingly simple can have clinical implications. Someone's scheduling an ultrasound to rule out a blood clot. Well, turns out if the agent goes and schedules that for 3 weeks later, lo and behold, they not only had a blood clot in their leg, but it moved to their lung called a pulmonary embolism, and they had a massive, cardiac arrest from this and ended up in the ICU or even died. Who's responsible for that? It was me? Was it my agent? Like, did my EMR do that without my approval? Was this thing off and running? What did it have permission to do? And that's when it was doing things it was told to do, right? So, like with the human in the loop kind of configuration, you could imagine an approvals process not unlike we use for medical students or residents now, where an agent is doing something, but it's going through the GUI and it's doing things, but at a certain point there can be workflows that call out for authentication. And an IAM vendor like Imprivata, we could go and do all the same value prop we normally do around security, checking the analytics behind it, but also verifying that approval and working with the records and the systems to give authorization for that order to actually happen or not. And that's one paradigm. I know that's a lot, so maybe I'll pause there and then we can go on and talk more about some more AI that's just more API integrated.
Well, I would just want to clarify. So you're like, it's not saying play fast and loose and sort of have agents review the agentic malpractice that's happening, right? And it's just agents to agents talking. Humans have to be in there reviewing. It's like, yep, the agent messed up, and so the agent in charge of that agent will sort of review and decide if he stays. We continue to power them on or not.
I mean, this is happening now with pre-authorizations and claims. Like, there's absolutely AI on the provider side talking to AI on the payer side, and so but even in the clinical care loop, I think there's opportunity. Like we do that now, right? Like and there are good solutions now for clinical workflows and re-authentications. We talked about electronic prescribing controlled substances earlier. Like, people wouldn't dream of not having an approvals process in place for when a student or a resident or a doctor does something that's high ticket like that. The point is, if an agent does it, we need to have the same or if not more control of that. And so that's one major paradigm. I mean, the other one, which is even more complex, is if these agentic AI agents are actually just directly hooked in by API integration, and they can just perform the tasks. And so in those cases, this is almost, in our minds, more like a PAM or a VPAM scenario, where similar to how you treat privileged access management with very important actions and very important systems, you want to have extra control and potentially time box that or rotate those, and really granular controls on what an agent is allowed to do, and the governance around that. And so some of the lessons we've learned and some of the tools we have for human access management, I think, can be really well used for agentic. There are some complications there, and there's some higher stakes in some ways. I don't know, I'm curious, you guys, your perspective.
Yeah, and there's plenty of stuff. I mean, like you said, this is happening, right? I think someone brought it up recently that prescription refills are happening via agents, and so it's a little bit interesting trying to sort of build a plane while flying it, because sort of agents are out there, and the sort of controls and governance around it are not necessarily, but it's got massive promise. I know Chip has a lot of perspective.
Well, and yeah, I mean, we're looking at we're talking about all the time, right? But they talk about ephemeral access, and then we talk about really least privilege. You talk about scoped access, all of that kind of stuff. I think this podcast, one of the things we obviously wanted to start on was just sort of that traditional human clinical problem, and just tying it back. The thing that I do think is interesting when we talk about some of the agentic pieces and we talk about doctors, nurses, clinicians, ultimately, I think in healthcare, the problem that we're going to see across a lot of it is legacy. There's this legacy stuff that hospitals can't seem to be able to get rid of. And whether that's now I need to go provide very fast access for Dr. Kelly to this particular system that's been around for 25 years because it has, imaging or something that I need to get access to, or an agent needs to be able to go get to that system. Either way, we're sort of still stuck with this problem of it doesn't support the modern standards. It doesn't give us an easy way to go integrate with it. And so we've got to come up with a consistent way to do the cool new stuff that's modernized, Sean, that you sort of hit on earlier, but also solve some of this old stuff. And I just would sort of going back to some of the passwordless stuff. Sean, I think that feeds into at least how I've heard us talk about this. But where do we start with that? How do you make that work if we're talking about sort of looking at some of these pieces and really making a customer successful as they need to roll out, I think, both types of technologies, for lack of a better way to put it.
Yeah, have you guys been to Rome and seen the Colosseum?
I have, yeah.
Yeah, so like I always think of healthcare technology like when you go to the Colosseum, you're standing on top of it, but when it's all like kind of decrepit and rotted away and like there's layers upon layers and like you kind of look down a layer and that's a couple centuries ago and then a couple centuries ago and a couple centuries ago and everything is built on top of everything else. And healthcare tech is like that. Like there are just messy old systems that we've built upon and there's no getting away from a lot of that foundational stuff for at least the next few years. And so I think you're right, Chip. Like that hybrid environment with the legacy and the modern, and cloud and even on-prem somewhat left over. And sometimes you just that's even just with the clinical systems. When you're talking about like supply chain and other operational systems and billing systems, like of course we try to get some of that modernized and easier to work with standards. But the truth is, it's messy. And so I think we'll go back to what we talked about before. Even though it's complex and you need technology that can work with all of the above, you have to optimize so that for the end users, it doesn't feel that way. And sometimes having a really modern IAM layer allows you to tinker with stuff and switch from A to B in the background and slowly evolve and modernize without the end users having to lift and shift everything that affects their clinical and operational functionality. Because at the end of the day, like we have to move patients in and out of the ER and get them admitted, and we have to do operationally what we have to do. And you got to fly that plane. You can't just re-engineer everything. And so I really do think it's you have to be cognizant of the effect on the end user and always increasing productivity and efficiency and then doing more with less from a financial standpoint. And technology can absolutely help us do that. And identity is at the crux of all of that. Because if you know who someone is and what they're trying to do, the pathway and how you get them there, you can wiggle that around and change it. And sometimes they don't know anything other than it got a little faster.
Yeah, I think the dynamic, those constraints, though, for many people is maybe one reason it feels hard, right? That can be a little bit paralyzing. It's like you need to change everything, but also change nothing for the end user. Or statements like that can feel sort of exhausting. And so I think many teams end up going, if I can't change the end user experience, I can't change, which isn't true. But I think you're right. Like healthcare, because of the dynamics of moving people in and out and like, humans and life at stake and stuff like that. The weight of change, I think, can feel paralyzing for some people or just really hard to do.
Yeah, but I think I don't know. I really liked what Sean said there. I think what you just said is right too, but I also firmly believe that there are the technologies out there now to do a lot of this. And that's what's exciting, right? If you think about where we've been with passwords and even Imprivata's value proposition from a while back, it's hey, we're gaining efficiency by doing this badge tap thing. But now we have the compute and we've got the storage and we've got the algorithms and all the stuff to really start to look at what I think Sean was hitting on, which is what's normal for an individual user so that we can still allow this while still doing it in a secure way so that we can make those incremental changes. And I think to me, that's like the big difference. And then the next thing that's going to sit on top of that is, okay, full circle, how do we now do this for agents, which is a whole nother level of scale problem, which will be super interesting to work through agents and make sure we,
right?
Yeah. Yeah. So, yeah.
And, I think one of the other elements here is that technology experts, especially on the industry side, shouldn't be afraid to be expert and to be prescriptive and to help guide provider systems that are sort of overwhelmed right now. And so the most important question that I always make our people ask to their own end users is, what are you trying to do? not like what is your tech stack and what is this configuration and what do you do now, but like literally tell me your ideal plan. Like what are you actually just trying to do here? Oh, well, I want to just do this note, or I want to get this data. I want to access my electronic record, or I need this supply chain software up and running while I'm doing this other thing. And oftentimes you have to ask them 3 times before you get the root of like, no, don't worry about all of this confusing stuff over here. Just tell me when you walk up to this endpoint or when you pull out your phone, what are you trying to do? And oh, I'm just trying to do this. Okay, let us go figure out with our provider side partners how best to do that for you and then migrate towards that, right? And everything in between can be complicated, can get simplified, can evolve. But it's not until you understand what they're actually trying to do or what they should be doing that you can actually do all that other stuff. Because you can spend years architecting and configuring, and if ultimately you're doing what they actually don't want to do because they told you a wrong thing because you didn't ask the question right, then that makes all the difference. So
just ask 3 times.
Yeah, ask 3 times and then get to the most simple version of what they're trying to do. And then it can be complicated, but then you got to be prescriptive about this is the way you get there.
Well, that's my general rule before I put anything on the roadmap.
Yeah.
Sean has to ask 3 times.
Yeah.
And I just keep asking until I get what I want.
Oh, well.
Yep.
There is that. Well, cool. I think that it's been a great discussion, Sean. Anything you're looking for, from your fellow sort of executive clinicians that are out there, the CNIOs, the CMIOs, all those out there in the world, or CISO CIOs?
Yeah, lead from within. I think that people that have grown up in healthcare for 10, 15, 20 years need to make their voice heard. Like nobody else is going to solve a problem for us. We need to lead from within. So, get to know your IT and your IS colleagues. They don't bite that often. And sometimes it's, doesn't hurt that much anyhow. So it's good, and Chip and Joel can speak to this. Like we're in deep, we roll up our sleeves and whiteboard together all the time. And it's gratifying. And nobody knows the problem better than we do from within medicine. And then, getting colleagues that are brilliant, especially from outside of healthcare, to help solve that is really gratifying. But it takes leadership from within. So I would just say get involved, do one thing a day, reach out to us, reach out to other colleagues. We'd be happy to connect you. There are lots of friends out there that are like-minded, and it makes a big difference. And it's really fun when it starts to work.
Great. And I know, you're a minor celebrity on the healthcare trail, but I know you're going to a couple conferences coming up here. So what you want to plug those just real quick?
Absolutely. I am on the Chime board, and we participate in Vive, a great conference out in Los Angeles, February 22nd to 25th. So hope to see everybody there. I would love to connect with anyone, either at our booth or any of the Chime events. We'll see you out there. Happy to get you a coffee or a drink or share a meal. So please join us there. We'll also be at HIMSS coming up in Las Vegas, March 9th to 12th. And we'd love to see you. Look, book a meeting with us, come meet us, just chat with us, hook up with us online, social media. We love talking to people. So
seriously, he is one of the most popular people. It's surrounded when we're there. It's a lot of fun. So, well, cool. Well, this was a great conversation. Sean, thanks for joining us. Joel, any parting thoughts on your side?
Yeah, thank you, Sean. That was wonderful. Appreciate the insight.
Nice to chat with you guys, as always. Cheers.
Yep. All right, see you. Thanks for listening. Don't forget to subscribe, share, and follow Access Point on your favorite podcast platform. We also welcome your feedback. Please send us any thoughts, insights, or suggestions to accesspointpodcast@imprivata.com or find us on LinkedIn. Until next time, I'm Chip and he's Joel. This has been Access Point.